Hello and welcome everyone. You have seen this, you have chased it, and even you have feared it. Lactate is a misunderstood molecule in our modern critical care. The fallacy definitely lies in that oversimplification. Today we will be busting 9 myths regarding lactate. We will know whether it is a villain, whether it is a victim, or simply it's just misjudged. So let's go ahead. The myth 1: elevated lactate equals hypoxia. Well, the truth is, not always. Lactate can rise in fully oxygenated tissues as well. In septic shock, studies have shown normal or even elevated tissue oxygen levels. The lung, which is the most oxygenated organ, is a major lactate producer in sepsis. So, what is driving all this? It is the adrenergic stress. The epinephrine ramps up the glycolysis, increasing the pyruvate and thus lactate without hypoxia. Think of lactate as a stress signal, not just a hypoxia marker. The next, elevated lactate equals the patient is in imminent death. Well, wrong again. The truth is, not all hyperlactatemia is life threatening, and not all sick patients have elevated lactates. So, you have other reasons like alcohol, decay, beta agonists, panic, which can cause elevation in the lactate. But surprisingly, patients on chronic beta blockers may have deceptively low lactates even in septic shock. So, elevated lactate is not necessarily a reason for imminent death. So, the next myth: lactate causes acidosis. No, it doesn't. Lactate is all generated from, it consumes the protons. It is already dissociated at the physiological pH. Generating lactate from pyruvate actually consumes these protons. The real acidosis and shock comes from the ATP hydrolysis, not from the lactate itself. So we should not blame the bystander. So lactic acidosis is a misleading term. Lactate associated acidosis is more proper. The next myth: lactic acidosis leads to hyperkalemia. Well, only with inorganic acids. In lactic acidosis or ketoacidosis, potassium can actually fall. Why? Because organic anions like lactate can enter cells, activate the sodium potassium ATPase, and shift the potassium inwards. So, insulin deficiency, not acidosis, is the bigger culprit in the decay related hyperkalemia. The next myth: we should resuscitate to normalize the lactate. Well, the statement is partially correct, but you should be careful. Lactate clearance isn't true clearance. It reflects a balance of production, utilization, and metabolism. Yes, decreasing the lactate is often good, but blindly chasing the numbers can be definitely misleading. So focus on reversing the underlying pathology and not the number of the lactate alone. Sixth myth: only arterial samples and ABG lactate is reliable. Well, not really. Venous samples just as good if collected properly. Immediate analysis avoids spurious elevations, avoid tourniquet delays, and obviously do the test immediately. But beware of ethynyl glycol poisoning. Portable analyzer may misread the glycolate as lactate, causing what is known as a lactate gap. Finally, lactate is just a metabolic waste. Well, it's not. It's actually a valuable fuel, mainly for the heart and the brain, which use it readily, especially during the stress. It also regulates inflammation, immunity, and even gene expression via the histone lactation. So it's not really waste, it's more of a wisdom. So it's a powerful multi-purpose metabolite, not really a waste. Uh, Next, avoid ringus lactate in hyperlactatemia. Again, a very common myth that we have. Well, it's clearly outdated now. Ringus contains sodium lactate, not lactic acid. It metabolizes to bicarb and helps buffer the pH. So even in sepsis, it is safe unless the liver is truly failing. and dose is much less than daily physiological lactate production. So RL is definitely not a contraindication if the patient is having high lactates. Finally, the last myth, lactic acidosis always involves L-lactate, not necessarily the D-lactate. A different isomer can cause acidosis in short bowel syndrome, propylene alcohol toxicity, and DKA. But standard lab tests do not detect this D-lactate. So know when you should suspect that this could probably be elevated. So the final take-home message is that lactate is definitely not our enemy. It is a biomarker, it is a fuel, it is a signal, and sometimes a red herring. So do one thing, use it wisely, interpret in the context of the clinical status, and always ask this vital question before you make any interpretation. What is the story behind the number? Without knowing the story, it is going to be very difficult for you to understand why the lactate is elevated, how I am going to treat it. Thank you for your patience.